Okay, good afternoon, everybody. I'm David Leighton Brown. I'm the master of Calumet College, and welcome back to Calumet. As I was just explaining to our speaker, people who are coming to Calumet College for the first time inevitably find that it takes longer than they thought it was going to take. And so we never quite know when the people who are aiming to be here have arrived. So I'll talk for a little bit by way of introduction to let stragglers make their way in. You all know why you are here, but I wanted to explain a tiny bit about the context of why you are here. A series of surveys of students, especially in the Faculty of Health, but also elsewhere in the university, have told us over and over that students want to get to know faculty members better. And especially, they want to find out what faculty members do with their time when they are not standing in front of a class. And that led us at Calumet College to create this particular series, imaginatively called the Faculty Research Profile Series. What I do in inviting people to speak in this series is ask 2 or 3 very simple questions, and then the answers to those questions give a wide variety of fascinating presentations. I ask, first of all, what are the questions that have interested you so much that you've devoted your entire career to looking for answers to those questions? And secondly, how do you look for answers to those questions? What do you actually do? And third, what are some of the really interesting things that you have learned in the years and years and years that you have been trying to find those answers? Now, the second bit of context, I'm assuming, but I shouldn't assume, how many of you are health policy and management students? I assumed you were. As you probably know, a change has occurred with regards to the affiliation of health policy and management students. This year, for the first time, all first-year health policy and management students are now members of Calumet College. Next year, all first and second-year students will be, and then all first, second, and third, and finally, in 4 years' time, all health policy and management students will be at Calumet. When we knew that health policy and management was making the shift, I knew we would want to have members of our faculty research profile series from health policy and management. So over the summer, I met with members of the executive of SAMPI, that you all know what it is, the Student Association of Health Policy Management and Informatics, and I asked them, which of the faculty members in health policy and management would be the best for me to invite to do a faculty research profile talk? And without thinking, they instantly and unanimously all said, Joel Lexchin. That gave me really great leverage for approaching Joel to ask him to talk, and not surprisingly, he agreed to speak today. You, if you don't already know, will find out as soon as I stop talking why the students in the program think Joel is the ideal person to launch this part of our series. The little tiny bit of a bio on the poster that you all know caught me by surprise. This is a fascinating background for someone to come to York University with. And I'm not going to try to put any more words in Joel's mouth. I'm going to turn, not this microphone, but the microphone that I think you're wearing.
No,
you're
I'm
not.
going
You're
to use
going to use this one.
Yes.
Over to you.
All right.
Thank you, Joel.
Thank you.
I look forward to it.
Okay. So this is, well, first of all, thank you, David, and whatever anonymous students you talked to who thought that I would be a good speaker for this series. I'm very happy to be here. And hopefully by the end of this talk, you'll be happy that you were here. So this is a small group, so if you want to interrupt, feel free to do so, ask questions whenever you want. There's no, this talk is going to ramble a bit, and there is no real ending for it. So just, as I said, interrupt, and we can engage in a dialogue rather than me just speaking all the time. So the title of this is going to be shown in pictures. I only have a few slides, which usually comes as a shock because doctors aren't supposed to be able to talk without slides. But so here is sort of the start of my journey that ended me up here. So back in 1969, there was, that shows you how old I am, there was a occupation of the Senate chambers at the University of Toronto in support of a group of women, mostly women, who wanted to set up a daycare center on the U of T campus. There was no daycare at U of T at that point. So first of all, we walked into the main administrative building, and we sat in the hallway for a while and asking to meet with the president, who at that time was Claude Bissell, and nothing happened. So somebody kicked in the door of the Senate chambers. I don't think they were damaged very much. And we all marched in. There were probably a couple of hundred of us to occupy the Senate chambers until we got what we wanted. And so this is a picture. You can see there I am over here. And this actually is, for those of you who may know, that's Craig Heron, who teaches history here now. So we were in the Senate chambers. This is a picture that appeared in the Globe and Mail. And we occupied it for 24 hours. After the end of the 24 hours, the president of the university agreed mostly to our demands. So we cleaned up and left. And for some reason, the Globe photographer took another picture of me. So there I am at the time of the cleanup from the occupation. So that was 1969, and that was a time when there was an awful lot of political activity, left-wing political activity going on the U of T campus and in campuses all around North America by and large. So that started me off being interested in political issues. The next thing that you have to recognize is that I ended up going to medical school and went from 1973 to 1977. This obviously is not a picture from that time period, but I went to medical school and didn't really know what I was going to do in medicine, and mostly by happenstance ended up working in an emergency department. And that, in fact, is largely the story of my career, that if any of you think that where I am today is where I thought I would be at any point up until I joined York, well, you're wrong, because I had no idea what I was doing or why I was going to do it. A lot of this is just as I said, happenstance, being in a position where something came along and I decided to take it. So the emergency department was largely because I had spent a year in New Zealand in 1981 and came back to Canada, had no job, had no real commitments anywhere, and there was a job opening up in the emergency department in Hamilton, so I took that, and then, but lived in Toronto, decided that after 6 years, driving back and forth on the QE was going to get me killed one day. So I took a job at the University Health Network, which is actually the name of Toronto General and Toronto Western, and we go back and forth between emergency departments at these two sites, and I've been doing that now for 24 years. And there I was, happily working in the emergency department, seeing people, saving lives on an hourly basis, but all the while being involved in some kind of political activities around medicine. And that's what led to this. This was actually early on in the my emergency medicine career, and I started writing this book back in probably 1979. I had finished a family practice residency in Halifax. I also didn't have a job then, and so I sat in my living room with 2 pads of yellow paper, and I had a big, sort of like that chair there, but with bigger armrests. And so on one arm of the chair, there was a stack of reference material, articles that I'd photocopied or books or what have you. And on the other was the yellow pads of paper. And I started writing the first draft of what became this book, which was, as you can see, about the pharmaceutical industry. And it was a runaway bestseller. So I think they printed 2,500 copies. All of them got sold, and then it went out of print. So now I don't even think you can get a hold of a copy on Amazon. They just don't circulate anymore. I believe I have a few copies left in a box somewhere in my house, but I didn't get rich off of this book. But this book was sort of the start of more or less why I ended up here, because this was the start of the book was the start of a research career that focused on pharmaceutical policy. And I focused on pharmaceutical policy for a number of reasons. One was because I saw this as a very political kind of issue for a number of reasons. So one of them was that there was a lot of money being spent on drugs, even more now. I mean, we spend $31 billion a year on drugs in Canada I think it was 2010, that's the latest year. Even back then, there was a lot of money being spent on drugs. The drug companies were quite powerful, even more so now. The government didn't seem to be taking these issues seriously, and there seemed to be largely an issue around social justice, that there were products being made that really didn't fit the needs of what people, or the medical needs of people. The products that were being made then and still now were basically designed to fill the pocketbooks of the people who own shares in the drug companies, which, from their point of view is quite natural and to be expected, but not necessarily the best use of research talent and the best use of money. So And this social justice issue tied in to the political activity that I started to be involved with in the late 60s and was involved with at this point, and continue to be involved with. And as I said, this book was sort of the start of the research into pharmaceutical policy areas. And then this book, about 8 years later, was followed by this book, which dealt with how drug companies promote their products in developing countries. And if you think that things are bad in Canada or the United States, you ain't seen nothing yet, because they're considerably worse in developing countries in terms of what the companies do, the way they act. This book was also a runaway bestseller. I think about 750 copies were sold, never reprinted. And that was mostly the end of my book writing career, because I decided book writing took too much work. So I just write chapters for other people and let them do the work. And I also do write a lot of medical journal articles and occasionally some stuff in the popular press. So after this, this book came out, oops, that shouldn't be 84, that should be about 92 when that book came out. And I was still in the emergency department, still seeing patients, writing on and off about the drug industry, because one of the things I found about the drug companies was that they always provided a lot of material to be critical of. This is like the person who says something that's somewhat off, and then keeps repeating it, shoving their foot deeper and deeper into their mouths. And the drug companies seem to have a talent for doing that, for shoving their feet into their mouths. There are always issues around what they do and how they do it that will generate material to be researched. So I was, as I said, still working in the emergency department at that point, still writing about the pharmaceutical industry, occasionally going and appearing in front of Senate committees or House of Commons committees, or doing other such things. But primarily, I was a clinician in the emergency department, doing shift work. And then back in 2000, that was when there was a strike, wasn't there then? Faculty strike? Or no, okay. 2000? Maybe it was a graduate. Okay, there was a strike here up at York, but at the same time, they were looking at setting up the School of Health Policy and Management. And one of my friends, Pat Armstrong, who teaches in sociology, who I'd known since the late 60s, knew that I'd always been interested in policy issues, health policy issues, and said, why don't you apply for a position in this new school that was being set up? And I thought about it for a bit and said, well, okay, why not? So I sent off an application, and then they called me up for an interview, which surprised me. So I went for the interview, and then they called me up and asked me if I wanted the job, which surprised me even more. And so I thought about it for a while. My wife encouraged me to take it because she thought that I would quit the emergency department and take the job up at York, and that my life would be somewhat saner. So I ended up taking the job at York after not really knowing what I was doing, because as I found out later, there's a lot more to being a professor at a university than standing up and talking to students. Not that teaching isn't a very difficult task, but there are also a lot of other things that you have to do that nobody bothered to tell me about, and if they had, I might not have taken the job. Anyway, so I took the job. I also made my wife even more frustrated because instead of quitting the emergency, I just took the job up at York and kept working in the emergency, although not quite as much, and have been here now at York for the past, well, this is the 12th year of the program. Our first day of class, as it turned out, for our program was 9/11. So as the buildings were coming down in New York City and other places, we were standing up in front of our first class giving a lecture. So over the past 11 or 12 years, I've continued to focus my research on drug companies or activities around drug issues, and continue to work in the emergency department and figured out what it means to be a university professor. And the last of the slides is this. So this is the most recent piece of research that I did. This was an article about a study. This was on the front page of the Toronto Star a couple of weeks ago. Below the fold, as they call it. So if you're really good, you get to be on the top part of the paper on the front page. If you're not quite as good, your story goes on the bottom part, and this was on below the fold, as it's known, but still interesting enough, at least for the Toronto Star, to put on their front page and feature. And this goes into what happens with new drugs once they're approved. Is there a difference in how long Health Canada takes to approve them and how safe they turn out to be? And at least based on what I could find, the answer is yes, that if you approve them too quickly, they have more safety problems once they're marketed. So that is the end of the slides, hopefully not the end of the talk. So to try and answer David's questions, let me first say that I am in a very privileged position, which I am I admit quite readily that I don't need, a lot of university people need money to do research. You need money to go to conferences. You need money to hire people. You need money to travel to meetings. I don't. Between working at York and working in the emergency department, I have more than enough money to do most of the things that I want to do with respect to my research. And in fact, when I get frustrated and I think about quitting one job, that's fine, because I still have the other one. So money is important, and that's given me a lot of independence to say a lot of things and do a lot of things that other people may not be able to do. And the driving force still behind the kind of work I do has to do with issues of social justice, and that's how I became involved also with a number of organizations that have the same general focus as I do. So I'm involved with an organization called Health Action International, which deals with drug policy issues. It's based in Amsterdam. I just came back from a meeting there a week and a half ago. I went to the meeting on my own ticket. Nobody paid for it. So I said, I can do that. And so I've gotten involved, and there's another organization in Australia that I'm involved with. I don't go to Australia quite as often because you can't do that for a long weekend the way you can go to Amsterdam. But I'm involved with a variety of groups that operate on a global basis, doing drug policy work, either in developed or developing countries. And that's a source of, well, first of all, it's a way of finding out about issues. But one of the important things when you're somewhat on the fringes, which is the sort of work that I do, if you're on the fringes, it's important to know that there are other people who are out there who are doing the same kind of work that you're doing, that you're not alone in this world. In fact, going back to medical school, a lot of people go into medical school with one set of values and come out of medical school with another set of values. And one of the reasons that they do that, or that happens, is because they end up in the medical, they end up learning about the culture of medicine. And the culture of medicine is much different than what goes on in the rest of the world, for a variety of reasons, some of them good, some of them not so good. But if you want to retain the values that you go into medical school with, it's probably important to also know that there are other people in your class who have those same values, because you can reinforce each other. And that was one of the things that fortunately happened to me in medical school, and has also been happening with this drug policy work. It's being through these global networks, and there's a network in Canada, is learning that there are people out there who are doing the same kinds of things that you do, who share the same values as you, and who are willing to engage with you in constructive dialogue. So they're not attacking the foundations of what you believe in. They may be attacking or criticizing your research, but they're criticizing it from a point of view that understands what your motivation is, and what the basis for what you're doing is. So I'm involved with them. I'm involved, there's a network of people across Canada who do drug policy work. It's called the Pharmaceutical Policy Research Collaboration. There are about 20 of us. And the drug policy world is not really much different from any other area that you get involved with. The deeper you go into it, the more you learn that it's a complex world. That, back when I started this whole thing in the late 70s, it seemed like it was much more black and white than it turns out to be. This is anything that goes on with government, with industry, is much more complex than it appears from the outside. And it's that complexity that also provides the windows for the research that you do. You pick up on issues that people are talking about, that interest you, and you're able to engage in that research because of the people that you know, and because you gradually learn where is the information, where is the data, and how to manipulate it or how to use it. So I do that. Where do I spend my time? Well, I actually spend most of my time sitting on my couch in my living room with the computer on my lap, writing. There is nothing really glamorous about this. A lot of, anybody read The Constant Gardener? No? One. Anybody know who John le Carré is? Spy novelist. John le Carré wrote The Constant Gardener back in, I think it was about 2003 or 4. It's a novel about the pharmaceutical industry. Part of it takes place in Central Africa, I think in Kenya. Part of it takes place in Germany. Actually, if you go and either read the book or watch the movie, there's an organization in Germany that in the book is called Hippo, which is a group of people, third world activists, doing drug policy stuff. Well, that's a real group in Germany, except in Germany it's called Buko, not Hippo. Part of it takes place in Canada, in an unnamed Midwestern city in Canada that looks a lot like Saskatoon or sounds like Saskatoon, that involves a character which is based on Nancy Oliveri, who used to work at sick kids and who got in trouble because she wanted to protect her patients who were taking part in a drug trial that she came to believe was unsafe, and she got in trouble because of that, both with sick kids and also with the U of T. Anyways, the point of that ramble is that doing research in drug policy is, by and large, nothing like what John le Carré writes about. It's looking at data. Well, first of all, you have to know where to look for data. And that's, again, where networks of people come in, is helping you figure out where to go for things, where is the information. If you don't know it, chances are that somebody will. So you're looking for information, and then you're trying to figure out how to analyze it. What's your issue? What's your question? And does the data support what you think? Does it refute what you think? That's the other thing. I'll go on another slight tangent here, is that everybody has biases, whether or not they admit it. We all have a point of view in the world. We all approach issues from a particular perspective, but it's also important, in order to maintain your credibility as a researcher, that you're honest. So when you're looking at the data, you have to go where the information sends you. That it's important to acknowledge that if it doesn't support what you think. So if you think that there's something out there that shows that the drug companies are evil and doing all sorts of bad things, and it turns out that that's not the case, you have to be willing to say that. So people often, or some people think that because I'm opposed to the drug companies, I will be against things like vaccines. Because there are various theories out there about vaccines. Now, I may think that policies around vaccines are bad, that the way that which vaccines are being used or promoted is not in the best interests of the people who may need them, and that other things should be done. But I'm not opposed to vaccines. I think vaccines are probably a very good idea. Well, they are a good idea. But people sometimes are surprised by that. But again, as I said, you have to be honest about what things what you're finding. Otherwise, you'll be out on a limb and somebody will be sawing off the limb that you're on, and you'll lose your credibility. One of the things that's happened to, or one of the things that's never happened to me is that people may not like what I have to say, and people may think that I have an axe to grind, but nobody has ever been able to accuse me of being dishonest, of covering up things, or of lying about what I found, because I, at least as far as I know, I haven't done that. And as long as you can maintain your honesty, it becomes harder for people to attack you. So I often get asked, well, has what you've had to say affected your medical career? And the answer is no, it hasn't. You know, I've made mistakes as an emergency doctor, but by and large, I'm pretty good. I know what I'm doing. I'm reasonably nice to the patients, and I don't get attacked. So when I speak out about the drug companies, people can't use that to attack how I work as a doctor, because they just don't have any, that doesn't have any credibility. So you have to be honest with what you find, but you know, a lot of what we're doing when we're doing this is we're writing, we're talking. So these kinds of talks are one thing. We go in front of, or I've gone in front of Senate committees. I've gone in front of committees from the House of Commons. I give talks at various meetings and that kind of thing. So one of the other things that I've tried to do with the research that I've done is make sure that it's not just academic research, that it's not just publishing for the sake of publishing. That doesn't really interest me. What interests me is changing the world, or at least a little part of the world, and making sure that the kind of work that I do is going to have some practical application, at least theoretically, that it has a chance for changing things. And in my case, the change that I'm interested in are changes that mean that there is more social justice out there, that there are, in other words, that while drug companies are still going to be making in business to make money, that they're not just, that there's a recognition that they also need to be making products which satisfy real human needs and not only the needs of their shareholders or the people who work there. It means that government needs to recognize that there are issues around affordability of drugs, that there are lots of people out there who can't afford medication. They don't, primarily what's known as the working poor. These are people who are in low-income, low-wage jobs, non-unionized, don't have any benefits. These are people who end up being unable to afford the drugs that they need. So that's part of it, making sure that doctors are not swayed by the amount of advertising that the drug companies engage in to try and get them to prescribe their products. Anybody have any idea how much is spent per year in Canada on promoting drugs to doctors? Anybody want to take a guess? No guesses?
Billions?
How much?
Billions?
How many?
2, 3?
Yeah, about that. $2 or $3 billion a year spent promoting drugs to Canadian doctors. So there are something like 75,000 Canadian doctors. So that works out to about $45,000 per doctor per year. Yes?
How do they go about promoting drugs to physicians directly?
How? Well, there are lots of ways of doing it. So one of them is you run ads in medical journals, but that's really a small part of it. The main thing that drug companies do is they hire men and women to go from office to office to see doctors, to try and establish a personal relationship with doctors, and to get doctors, or they also leave samples of their drugs with doctors, and they try and get doctors to commit to prescribing the product. Again, who do you think would be hired to do this job? No, not doctors. Yeah, but where do they start their lives? Well, actually, yes.
University grads, right?
Yes, but at least at one point in time, there was a particular group of university grads. Well, you want people who are peppy, reasonably good looking, personable. Who fits that? I'm sorry?
Gazette.
Cheerleaders. So there was an article a few years ago in the New York Times that drug companies were going after cheerleaders to be reps for them. You know, yes.
We have a bunch of socially conscious nursing students in the audience. When you talk about the commercialization of pharmaceuticals, what is the pharmaceutical industry? What is that?
What is the pharma? Well, it used to be pretty simple as an issue, as a question to answer. Over the years, it's gotten more and more complex. So what is the drug industry? Well, there are the big name companies that you hear about, Pfizer, Merck, et cetera. But these companies are increasingly hiving off more and more of what they used to do. So you have, in terms of research, a lot of the research now, not all of it, but a lot of it is being done by smaller biotech companies who get the product to a certain point in its development, and then they sell that product to a large drug company because they don't have the money to take it any further. You have drug companies used to run their own clinical trials. Now they contract out the running of their clinical trials to organizations called contract research organizations, who then are the ones who manage the drug trials. The contract research organizations subcontract to companies that actually do the recruiting of the patients. The people who run the trial, or the people who actually run the trials, sometimes are often researchers who are paid by the drug companies to run the trials. The marketing is often done by public relations companies. There are many, many media companies that are involved with the pharmaceutical industry, so that you have especially in the United States, you have companies that are devoted to doing continuing medical education. These are for-profit companies that run courses for doctors, often with money that's supplied by the drug companies. So the drug industry is a whole network of different organizations involved at different points in time and doing different things. Yes.
So how does Health Canada ensure that those clinical trials are done adequately, particularly when researchers are hired by drug companies?
Oh, well, that's an interesting question. So first of all, as with all these questions, remember that I'm giving you my perspective, okay? Which I think is the unvarnished truth. But certainly if you talk to drug company executives, which I have, some of them are actually very nice people. They don't have horns or pointed tails or anything like that. They will not agree with what I have to say. So how does Health Canada ensure that clinical trials are being run adequately? That's a very interesting question. So first of all, before a clinical trial can be run, the drug companies have to submit what's called a protocol to Health Canada. A protocol is a description of how the trial will be run, and Health Canada has to approve the protocol. Clinical trials also have to be approved by what we in Canada call research ethics committees, or research ethics boards, what in the United States are called institutional review boards, what in Europe are research ethics committees. These are organizations that are groups that look at the ethical issues around a trial. So in other words, is it reasonable to do this trial in this particular group of people? Are the people, what's the risk involved to the people who are engaged in the trial? Are you going to get informed consent? How are you going to get informed consent? How are you going to make sure or try and make sure that nothing bad happens to these people? So all of this goes through the Research Ethics Committee. Unfortunately, in Canada, there are no national standards for research ethics committees. So who should be on them? We have no national standards around that. And you get research ethics committees or boards will also have their own conflicts of interest, because you may be sitting on an REB at University Health Network, and somebody else from University Health Network is applying to run a trial, and you know this person, and do you give them permission to do a trial because they're a friend of yours? Is there a conflict in that? The hospital may have a conflict, because the hospitals, when they're going to do, when a company wants to do a clinical trial in them, hospitals automatically charge about 50% more than the cost of the trial. That's the fee that the hospital takes for making its premises available to the company. So the hospital may have an interest, or the hospital may have a share in something or other which is funded by a particular drug company. So are they going to be willing to turn down a trial from that company and risk losing the chair that they have? So you get through all of these things. You get the protocol approved, you get the trial through the Research Ethics Board, and then you're allowed to run the trial. But in fact, how well the trials are, the companies are primarily in charge of monitoring how well the trials are being run. Health Canada does do inspections, but they only inspect about 2% of the trials that are done in any given year. So the last figure I read was that there are about 3,000 trials in Canada in any given year, so 2% is 60. And how do they choose the 60? Well, if you look at the Health Canada website, it says that they choose them based on how at risk they think the patients in the trials are. And how do they know how at risk the patients in the trials are? And they don't say anything about that. So they do some inspection, but it's unclear what their criteria are, and there have been the occasional horror stories around clinical trials. So there was one trial that was being done somewhere in Quebec, and it turned out that one of the people in the trial had TB, active TB, tuberculosis, which was not picked up by anybody for a considerable period of time. So, that trial should not have been running, at least not with that particular patient in it. So clinical trial issues are a serious problem. We just had Leona Glukek, who is the Federal Minister of Health, making an announcement that there is going to be a website listing clinical trials being run in Canada so patients can look and see what's going on. Now, that is when I got called by a reporter about that, that's what I would term a non-announcement. Health Canada has been looking at clinical trial registration. In other words, when you run a clinical trial, you actually have to put into a database information about that trial. They've been looking at that, making that mandatory in Canada since June 2005. They still haven't reached a decision about that. In the United States and in Australia and in Europe, clinical trial registration is mandatory. In other words, if you're going to run a trial in one of those countries, you have to register it. And in the United States, you also have to post at least some of the results of those trials. Health Canada hasn't done any of that. Yes?
Along those lines, I think there's a way to fast track a research study as well, right?
Yes, that's...
Bypass some of the standards?
Not the standards. That's what there are a couple of things that can go on. So that's what this paper looked at, or the paper that was the subject of this article in the Toronto Star. So Health Canada has two processes for approving, well, actually three. This one looked at two of them. So one is called a priority review process, which is supposed to be for drugs that are significant therapeutic advances or treat untreated diseases. And the other one is a standard review process for all the other drugs. The priority review process takes 180 days. The standard review process takes 300 days. They're both supposed to look at the same level of information, or both supposed to do equivalent analyses of the data. It's just that one is done quicker than the other. But what this study that I did said was that if the drug went through the priority review process, there was a 1 in 3 chance that it would eventually have a serious safety problem, whereas if it went through the standard review process, it was a 1 in 5 chance. So a significant difference in the likelihood that they would eventually end up with safety problems. And this seemed to be due to the fact that if you rush the procedure, you miss things.
When you had this up before, I was really struck that only a 1 in 5 chance of a serious safety problem seemed to be a pretty low threshold. What could be done in a standard review to reduce the strikingly large number of bad mistakes that may happen?
Well, the issue around safety problems with drugs is related to a large number of factors. One of them, or the main one probably, is related goes back to the profit motive that the companies have. So the companies can't make money unless they get drugs on the market. And so they want to design their trials such that the trials are likely to show that the drug works. And what that means is that you end up with a very narrow range of patients who are in those trials. You want people who only have one diagnosis, because more than one diagnosis may interfere with what the drug is doing, more than one disease. You want people who aren't on a whole bunch of drugs because other drugs may interfere with the one that you're testing. You want people who have a clear-cut diagnosis. You don't want any of these maybes. You also don't want people who are so far down the road that nothing is going to help them. And so what you end up with is that in clinical and you also want the clinical trials to be done relatively quickly because you don't want to spend 5 years testing the drug because that eats into your patent lifetime. So you end up with trials that typically run 3 to 6 months at most, where about 1 in 100 people who have a problem are able to or get registered, and then the drug comes on the market, and boom, it's not just being prescribed for the people who it was tested in, it's also being prescribed for a 10-year-old kid or an 85-year-old grandmother who's on 10 other medications, and nobody knows, and they're taking it for a few years, and so nobody really knows what's going to happen. But the drug companies use these types of clinical trials because these are the types that allow the product to get on the market and to start bringing in some money for them. So if you wanted to change that aspect, you really have to remove the profit motive from drug development, and that's not likely to happen at any time in the future. Other people have questions, or should I go back to rambling? Yes, way at the back.
We did a study on the HPV vaccine.
Yes.
Can you comment on the clinical trials about Gardasil?
All right.
By Merck.
Yes. So this is somewhat controversial, and it depends where on the political spectrum you happen to be, whether or not what particular aspect you find controversial. So if you're on the Christian far right, what your concern is that if you give the vaccine to 12-year-old girls, they're going to go off and have sex every day. Because the attitude there is this is going to promote sexual promiscuity. If you come from the somewhat conspiratorial theory that this is an unsafe vaccine which should not have been marketed, and may cause all sorts of problems down the line. If you come from another point of view, which is the one that I take, my point of view actually is that this vaccine is probably safe. We don't know for sure that it's actually going to prevent cervical cancer because it hasn't been around long enough. Cervical cancer takes 20 years to develop. But certainly the research that was done seems to show that it probably will against the strains of the virus that it's designed to attack, and that's only 2 particular strains They cause about 70% of cervical cancer, so there's still 30% that's not being protected against. So my point of view, though, looks at this as a policy issue, and that the federal government committed $340 million to getting the vaccine being used. So my point of view is, well, is this actually the best way to use the money? And is this going to reduce the rate of cervical cancer? And that rests on a few things. So first of all, you need a reasonably high uptake of the vaccine, which we don't have. The uptake is only about 55%, which is not enough to give you what's called herd immunity. Herd immunity, for those of you who haven't heard the term, basically is that if you get enough people who are vaccinated, that there's nobody, if one person gets the disease, there's nobody else that they can give it to, because everybody else has been immunized against it. So 55% is not enough for herd immunity. Who gets cervical cancer in the first place in North America? This is a North American-based analysis, not a third world-based analysis where cervical cancer is a much different disease in terms of the number of deaths that it causes. So in North America or in Canada, who gets cervical cancer? Well, the answer is, who gets it are the women who don't get pap smears. And who doesn't get pap smears? Well, marginalized women, women living in poverty, often Aboriginal women. And so is the vaccine going to reach these groups of women? And nobody really knows that, because even though it's supposed to be given out to 12-year-olds while they're in school, by that point, by the time you're 12 or 13, there are a number of girls who've dropped out of school. So are we going to reach these people? And even if you get one vaccine, it probably requires boosters, and are they going to get boosters? So my question is, and even if we are going to institute a program of vaccinating young girls, should we be doing other things? So should we be doing more to promote safe sex practices? Should we be doing more about making sure that people use condoms? Should we be, and the vaccination program had none of those aspects in it. It was strictly, here's money to pay for the vaccine. So I think that this is a particularly poor policy decision. But from the vaccine point of view, vaccine, as far as I'm concerned, is okay. Others? Yeah.
What benefits do physicians typically get when drug companies advertise certain products?
Okay, well, this is an interesting question. And the answer to this has changed somewhat. The industry has gotten, at least in this respect, somewhat smarter. It used to be that you could probably get at least one free trip a year to a conference with your wife or husband from the industry to go to a meeting somewhere in Canada. You can't get that anymore. Only if you're a speaker will you get paid to go to a meeting, but if you're just going to attend, you typically don't get money. But you do get other benefits. Oh, and you also don't get lavish gifts, which you used to be able to get also. What do you get? Well, first of all, what you get is, if you see sales reps, you get a break in the day. You know, if you're in an office practice, what's your day? People coming in and telling you about their problems. which is, that's what a doctor does, sits down, listens, does a little bit of an examination, tries to figure out what's going on and gives some advice or gives a prescription or what have you. But you're always listening to what's bothering people. What do the sales reps do? Well, they don't tell you what's bothering them. They go in and they do the talking. They're very nice. You can just sit back and relax. So you get a break in the day. Now you can't get invited directly to meetings, but the drug companies can give money to organizations to run dinners. So the Society for Irrelevant Results will put in, say to Merck, we're going to we want to have a talk tonight, or, not tonight, in a month or 2 months about X, Y, or Z, knowing that that's a topic that's of interest to Merck because Merck makes a product to treat whatever that is. So Merck will give them some money, and then they will go and rent a restaurant and invite doctors to go to the restaurant where now we are not going to McDonald's. In fact, we go to places like Canoe. Anybody been to Canoe? Probably not because you're poor students. Canoe is, I think it's on the top of the TD Center or Commerce Court, and the main courses run in the range of $75 to $100 a person. So you can get that. You'll hear about these meetings from the drug company sales reps. So you get good meals, free liquor, of course. You may, if you want to, you can go on to a speakers bureau for the drug companies. Drug company speakers are doctors or sometimes other scientists who are paid to go around and give talks for the company. And depending on where the talk is and what the audience is, maybe $500 to a few $1,000s to give a talk. So you can do that. So there are certainly benefits that doctors can get and you get free samples to give to your patients, except that you don't always give them to your patients. You might take them occasionally or give them to your family. But if you ask doctors why they see the sales reps, a lot of them will tell you that they see them to get the free samples to use for their patients. So there are benefits. Yeah.
I'm curious to know, do nurses have a role in the sales marketing techniques of the pharmaceutical company?
Okay, so how many nurses are there? Yes. Students, yes, okay. All right, so do nurses have a role? Well, the answer is yes. Well, first of all, some nursing students who are here who will remain unnamed used to be drug company reps. But no. So one of the things that companies do is that they will hire nurses to be sales reps. So if you happen to have been a nurse in, say, a dermatology clinic, you may be hired by a drug company that sells dermatology products, because having worked in the clinic for a while, you're pretty familiar with a lot of the diseases. You've worked with a lot of dermatologists. You know what they do, and that makes you a more credible salesperson. So nurses will be hired to do that. Drug company, if you have a nurse in your office, drug companies will often go through the nurse to get to the doctor, because sometimes the nurse is the roadblock. And if you're nice to the nurse will say something about your company to the doctor, and that will open up the door for the company to get in to see the doctor. You also have, early on in doctors' medical careers, the nurses who have been there for a while typically know more about therapeutics in the area that they're working in than the interns and residents. So drug companies will try and influence the nurses to influence the doctors. As an intern, you will go up to the nurse and you'll say, this patient has such and such, what's the usual treatment for that? And the nurse will give you some suggestions. And finally, as we get more and more nurse practitioners involved in being clinicians in Canada, nurse practitioners, at least one class of them, have the ability to prescribe independently. Now, they can only prescribe a certain range of products, but that range is reasonably broad. So the drug companies are now looking at influencing nurse practitioners, and nurse practitioners or at least some of them take the attitude, well, the doctors are getting all this attention or money or meals, why shouldn't we? So they're quite eager to get into this.
Are there any prohibitions for gifting the nurses or nurse practitioners, or is it just targeted at doctors that are prohibited?
Well, none of this is prohibited per se. So all of what regulation of promotion is one of the areas where Health Canada has theoretical power but has abdicated that power. So by and large, except for printed material, all other drug promotion is self-regulated by the pharmaceutical industry. In other words, they write their own code, they evaluate complaints, and they administer whatever or penalties there are. So the prohibition against flying doctors to meetings or giving doctors gifts or what have you is strictly self-regulation. And for those of you who study self-regulation, well, XL Foods or meat, that was an example where Health Canada was allowing the company to do a lot of self-regulation. Self-regulation, in my view, doesn't work. It doesn't maintain high enough standards. Sarah. Well, you know, that's a very good question. And in fact, the drug companies, as long as they behave legally, are doing what you would expect them to do. You know, these are for-profit organizations in business to make money, and we shouldn't be surprised that they will do more or less what's legal, and sometimes illegal, but not often, but they will do what's legal in order to make money. It's the healthcare professionals who really are the ones who should be attacked or criticized for what they do, because it takes two to tango. If the drug companies tactics weren't working, weren't influencing doctors, nurse practitioners, then all they would be doing is wasting money. The fact that they're spending so much money indicates that they don't think that they're wasting it. So doctors and nurses should be held accountable for what they do. Unfortunately, there is, at least with doctors, I don't know about nurses as much, but doctors have this idea that we can eat the food that the drug companies give us, see the sales reps, take the free samples, be on their speakers bureaus, and we're not going to be affected. Now, we're not so sure about the other doctors that we associate with. They're not necessarily as morally pure as we are, but individually, I can't be bought. And that's a pretty common perception that you find amongst doctors, which is why doctors feel that they can do all these things because they're scientists and they will not be swayed by this. They know what's going on and they can resist. They're going to make up their own minds. Yes. In the scarf, yes.
Can the drug companies track which physician is prescribing their medication?
Okay. Well, it's slightly unclear. There is a company that operates around the world. It's called IMS. IMS, and I think there are a few others that do the same thing. These companies have contracts with pharmacies. The pharmacies take the prescriptions that they have filled, remove the names of the patients, keep the names of the doctors, and then they sell that data to IMS. IMS then collates that information to find out what doctors are prescribing. And then they sell that information to the drug companies. So now in Canada, in the United States, this is done at an individual level. Individual doctor level. The data is analyzed by individual doctor. In Canada, IMS claims that they don't do it by individual doctor, but there's some circumstantial evidence to suggest that they might do it. But if they don't do it by individual doctor, they do it by geographic area, small geographic areas, so that the sales reps have a reasonably good idea of what doctors in a particular area are prescribing. And often, at least in the States, the sales reps know more about what the doctors are prescribing than the doctors know. Yeah.
Could you comment on some of the information that the drug companies now are shifting their efforts towards the manufacture of psychoactive drugs as opposed to other drugs?
All right, so
Because it's easy to approve and difficult to monitor?
well, it's not easier to approve. Drug companies have been traditionally interested in drugs that have two characteristics. Two? Yes, I think. One is that there are a lot of people with the disease or with the problem, and two is that the problem doesn't go away very quickly. So that's one of the reasons why drug companies are not making antibiotics, for instance, not developing new antibiotics, because while there's a lot of use of antibiotics, you only use them for short periods of time, a week, 2 weeks, and then you're finished with them. So drug companies are interested in things like high cholesterol, diabetes, high blood pressure. They're also interested in psychiatric illnesses, and one of the reasons that they're interested in those is because the diagnostic criteria are flexible. There is no test that I can do that says that you are depressed. All I can do is listen to you and make sure that the way you're feeling isn't due to something else. But so depression and various other things, bipolar, are all diagnoses that have no firm basis to be made on. So you can play with these diagnoses. You can make it's easy to expand the number of people who are supposed to have these diseases because there are no firm criteria for who does or doesn't. So that is the main reason why drug companies are pushing their products in these areas. That the use of them can be expanded. So it used to be that depression was a relatively rare diagnosis. So 40 years ago, depression was not something that you diagnosed all that often. But that's changed. Bipolar, which used to be called manic depressive, was again a diagnosis which was pretty rare. Now it's a lot more common. Drug companies are very good at expanding diagnoses, and they do that in a number of ways through the way that they promote products. So after 9/11, there was an ad for one of the antidepressants, which was also being used for anxiety, and the caption on the ad was something to the effect that about in this troubling world where nothing is certain, people are getting more and more nervous about what their future is, and in those cases, here is what you should use. Now that's paraphrasing the ad, but that's more or less what was there. Anybody know the Rolling Stones song that has a line about Mother's Little Helper? What's Mother's Little Helper? Those were tranquilizers that women who were stay-at-home mothers, worrying about their kids, worrying about the housework, etc., were supposed to be able to use to help calm them down. So these kinds, if you look, everybody know what the DSM is? Diagnostic and Statistical Manual. This is the publication put out by the American Psychiatric Association, which lists the criteria for diagnosing every psychiatric disease known to humanity and a few that aren't known. If you look at the makeup, there were 15, 16 different committees that were involved in producing DSM-4. That was the last version. The new one is just about to come out. But DSM-4 had about 15 or 16 committees, no, 17, of people that came up with the criteria for the diagnosis. And I think there were 2 of these committees where nobody had a relationship with drug companies, and there were some of these committees where 100% of the people who sat on them had some kind of a relationship with the companies that made products that could be used in treating psychiatric disorders. So there was also a conflict of interest in the way that the DSM-4 was, or the criteria that it came out with. Yeah.
So what are the criteria for?
Well, the criteria for making a diagnosis is what a group of people sitting around a table think they should be. Because, again, these are not diseases where you can do a CT scan or an MR or you can do a blood test or something else and you can say that you've got it. These are diseases where you come up with a series of points, and if you have enough of those points, then you have the disease, and if you don't, then you don't. And what are the things that you should use, and how long should you have each of these criteria, and how serious should they be? That is a decision that's made by the people who are on these committees. Yeah.
One more question. How about the criteria for trials of the medication themselves?
Trials.
Yes.
Okay,
Criteria.
well, again, you have to submit the protocol to Health Canada to get the trial approved. But if you've got the protocol summarizes what's known about the product, what's the laboratory information say, what's the animal information have to say, what are you going to be looking at, what are your outcomes? So, in depression, there are scores for depression, and the outcome might be a reduction in 5 points in the Hamilton, I can't remember the rest of it, the name of the score. That might be your outcome. You submit all this information to Health Canada. You also submit some information to the ethics committee, and if they approve it, you can go ahead. And then you have to recruit the patients.
I came late, so forgive me if you did cover this. I'm under the understanding that we would all assume, or many people who know about research would assume that the most stringent tests are done on drugs, so the random double-blind placebo model, like the highest level. But I've heard that actually it's quite a small percent of the drug trials or studies that are actually done using that model in the strictest sense.
No, actually, well, most drug trials are randomized double-blind. Now, whether or not they're placebo or not depends. There's a certain amount of debate as to whether or not they should be placebo. A lot of people are arguing that they shouldn't be because then if they're just placebo, you have no comparative information. So you have no idea. All you know is the drug works better than nothing. You don't know whether or not it works any better than what's already on the market. So there are debates around whether or not the trial should be placebo. There are a small number of diseases that are pretty rare, where it's difficult to get enough people to do a randomized double-blind trial, and in those cases you might be able to do what's called an observational study. In other words, you give the drug to a group of people and you follow them and see what happens. But that's not the common scenario. Other people? How are we doing on time? Oh.
Can we get back to your career?
My career.
Your career. So you're now you're a professor and an emergency room physician,
That's right.
and you've done them both for quite a while.
Yes.
Are you happy with this mix, or are you now at a point where one is boring you, the other one is not?
Well, things are always, it depends on the day. Some days I'm happy with both. Some days I'm miserable with both. Some days one of them is enjoyable. But by and large, I mean, one of the things that I find teaching health policy is that I think the students appreciate the fact that I can talk about what goes on in at least one part of the real world, although that's a very small portion of the real world of healthcare. And certainly there's this myth that doctors know more about healthcare than other people, which is not true. But it still impresses people. So you can go into class and you can be talking about something and you can say, and the last time I was in the emergency department, we saw, and you go off into, and you make up some story and it sounds really good and people go, ah. But being involved in part of the real world, I think, is useful for teaching, and also teaching and being up to date on health policy helps in the practice of medicine, because one of the things about the practice of medicine that you find is that for most people, this is a one-to-one interaction. Now, we don't in the emergency interact with people for very long. A long-term relationship is 20 minutes. But it's still you're doing things on an individual level. And you forget that there's a wider world out there. And that it's not just what's going on in the emergency department with that particular patient at that particular time, that doesn't make up all of what healthcare is all about. So doing health policy helps you remember when you're seeing patients that there's more to healthcare than just seeing patients. So they mutually reinforce one another. And as long as they do that, and as long as I can maintain doing both, and as long as my wife doesn't get too upset about me having 1 and a third jobs, I'll keep doing them, because by and large, they're both fun. Oh, one more? 2 more? All right, we'll take you first.
If there is one thing that you could do to reduce the expense of Canadian healthcare, what would it be?
One thing that I could do, that's an interesting question that I hadn't thought about. I guess the one thing that I would do is to try and teach the people who are doing healthcare, who are practicing, that a lot of times you don't need to do anything. Most things that happen to people, not all things, but a lot of things that happen to people get better regardless of what we do. And if we did nothing, it would would avoid side effects of our treatment, and people would be just as well off. But there's a feeling amongst people who work in healthcare that when somebody comes with a problem, they're coming because they expect you to do something. And if you don't do something, you will feel that you haven't fulfilled your duty, and your impression is that they will feel that they haven't got anything for their time. So one of the things that we sometimes hear from people coming into the emergency department is they come in, you listen to them, you examine them, you do whatever else you want to do, and then they ask you what should be done, and you say, nothing. And sometimes people will say, you mean I wasted all this time to be told that I didn't have to do anything? Well, yes.
You said that trials are only conducted from 3 to 6 months.
Roughly, yes.
So they don't look at long-term implications. So what do you think public can do to push government or pharmaceutical companies to, especially when it comes to antidepressants, to examine those drugs on patients on long-term basis rather than short-term 3 to 6 month period?
Well, you could do a number of things. You could try and get the companies to do longer trials, but that won't work. And I don't think government doesn't really, there's no government that I know of that's interested in doing that. So you could do other things though. So one of the things you could do is you could put people into registries. So a registry means that if you get a particular product, that your name goes into a protected database, and we can follow what happens to you over the course of the next, whatever, 5 years, 10 years, and you can look at what kinds of other healthcare issues you develop, if you end up being admitted to hospital, if you end up with particular other problems, and you can look for patterns. Now that involves privacy issues, which you'd have to deal with to make sure that the data is protected. The other thing that I would suggest is that unless a new drug raises people from the dead, or the equivalent, that no new drug should be, or any new drug should not be used widely for about 5 years. So you should only use that product if, one, there's nothing else that's out there, or two, if you've tried everything else. So new drugs should be used, and this doesn't just apply to antidepressants, new drugs in general should be used very cautiously and very slowly so you can build up experience with them and hopefully detect safety issues before they become really widespread. One of the things that happens currently is that drug companies want to make money quickly. So a new drug comes out, and a lot of them are advertised using tens of millions or hundreds of millions of dollars in the first year. And the idea is to get the drug used as widely as possible so that you start making money back, which means that you get all sorts of people taking the drug early on who you have no idea what it's going to do. Is it going to help them? Is it going to hurt them? How much is it going to hurt them? How much is it going to help them? And that's when you get a lot of unexpected safety problems turning up. So because the drug was never used in particular groups of people, and now it's being prescribed in them, and lots of them are getting it, and so you find people dropping dead or needing liver transplants or what have you. So if we use drugs very cautiously early on, you build up the information, and if you start seeing signs that there might be unexpected safety issues, you can take measures early on. Well, You want to let?
One more question.
All right.
Is it true that it's government policy that the drug companies, like Shoppers or whatever, when you go in to get a prescription, have to give you the generic unless specified by the doctor's brand name?
Okay. So in Ontario, I don't know about the other provinces, but in Ontario, by and large, the answer is yes. First of all, if you're covered by the Ontario Drug Benefit Program, you will get the generic name, generic product. Even if you're not covered, they still have to offer you the generic product. Now, you can pay more if you want. Some of the private insurance companies don't care which brand you get, generic or brand name. They'll pay for either because it's not their money, it's your money that you paid into the insurance. But yes, by and large, if there's a generic, you'll get it. And generics are just as good as brand names.
But there is a difference, is there not?
The difference is in the what are called the excipients. So a pill is made up of a whole bunch of different things. So there's the active ingredient, then there are the coloring agents, the stabilizers, the coatings, and a whole bunch of other things. So the active ingredient in generics and in brand names is the same. It's in the same concentration. It dissolves at the same speed. It gets into the bloodstream at the same speed. It gets eliminated from the body at the same speed. So when you get a generic, you may have a reaction to it that you didn't have when you were using the brand name, but you're reacting to one of these other things. The fillers, the coloring agents, the stabilizers, the coatings. And similarly, if you've been started on a generic and you get a brand name, the brand name will have different stabilizers, coloring agents, etc., and you may have a reaction to the brand name.
And some companies, they will subsidize the difference between the generic and their brand name.
They may.
No, they
That's
don't. I
okay.
know one that my doctor gave me a card, and I said, well, he says, oh, just give this to the card company, to the druggist or whatever, and the drug company.
That's an attempt to maintain market share, because brand name companies don't compete on price. If a generic comes on the market, the brand name companies do not lower their price to match that of the generic.
The only issue I take is that when you take a prescription in or whatever, they don't tell you you're getting the generic until you've got it. They never ask you, do you want a brand or do you want?
That's because there's no difference. I mean, the drugs I get, I don't care which generic I'm getting.
Well, we've really kept you
Okay.
much more time than you committed to. But I have one really quick question.
Yes.
Quick answer. Of the 3,000 clinical trials a year, statistically, what percent of the drugs get approved and what don't?
Well, if you listen to the drug companies, if a drug makes it to a phase 3 clinical trial, so there are 3 phases, phase 1, 2, 3. 3 is the largest and the last. That at that point in time, I think that there's about a 1 in 3 or 1 in 2 chance that the drug will actually be approved.
All right. Thank you very much, Joel. I know we could have kept you going much longer, and we will have to have you come back again in a future year to say some of the things you didn't have time for today. But every one of us, whether we're studying in one of these programs or we're ever going to use a prescription drug or we're ever going to go to a doctor, really learned interesting things here today.
Well, thank you.
In appreciation, I would like to bestow on you this Calumet College
all right.
bag
Well, thank you.
filled with Calumet College stuff.
Thank you.
And I really do look forward to having
All
you
right.
back again
Thank
someday.
you.
Thank you.